Okay. Uh, Hello to everybody. Thank you so much for joining. We've got some of our regular participants and some newer people as well. So please just remember, if you have any questions, you're more than welcome to stop me at any point and ask questions in the chat. And alternatively, you can, if you watch this later on, you can always ask questions on the WhatsApp group, Telegram group, or via the YouTube comments as well. So today we're going to go through the analysis of an ABG in a collapsed athlete. It's not really an ABG analysis per se, because we're really going to be dealing with hyponatremia today, but it was an interesting one that came up on X actually. And there was quite a nice discussion that went on with it. And having followed the whole thread, and okay, no problem about it. Thanks for putting that on the chat. It's no problem. But like I say, if there's any question, more than welcome to ask. It's fine. Um, it was a very interesting discussion that they had. So I tried to revolve the presentation around that as well. So this was the ABG of this patient who had presented to one of the doctors who is on X. And the patient was found having collapsed and had also had a bit of seizures as well. And he has quite a well-known athlete actually, and he was rushed into the emergency department there in the States. They of course use some of their levels are more the US levels, but we'll just try and go through it here. And what they found mainly was that his sodium was quite low, of 125 millimoles per liter, the slight elevation in blood glucose. They often have energy drinks and things like that, so there may have been something that just spiked his sugars a little bit. But this was the main thing that I wanted to focus on today, because hyponatremia is not something that's often readily apparent to us in the emergency department unless you have access to quick blood analysis, which we all should. We should have access to a blood gas machine, at least so that within 5 minutes we can have some sort of analysis that's done. Now, of course, in a young patient, collapsed, seizures, you wouldn't only stop at a blood gas. You would, of course, do an ECG. You would do a CT brain as well, if, of course, this were to come back normal. However, in this case, with the sodium being so low, they decided that they needed to attack that and really make sure that they got the patient back to more of a normal state. So we're going to talk a bit about hyponatremia and how we can try and approach it as well. So, anything below 136 millimoles, let's say to about 130, sort of like a mild hyponatremia. From 123 to 130 is moderate. And once you go below 123, then you're talking about severe hyponatremia as well. So, like I say, it was a young athlete. He collapsed during physical activity and presented with seizures, which is quite a common presentation with hyponatremia. Now, if you're not sure why, it simply has to do with osmolality. So once your sodium levels drop within your bloodstream, your let's say your extravascular cells, so it doesn't matter where it is, whether it's in the brain, in the kidney, in the tummy, wherever it may be, all of those cells now have a higher concentration of sodium. So what they do is, in order to achieve a balance, an osmotic balance, they start pulling fluid out from the intravascular space into the cells, so that the cells themselves can sort of dilute the sodium within them, so that they can have sort of a balance. So what happens is you start getting cerebral. In this case, well, you get cerebral edema. You can get cardiac edema. You can get, pleural pulmonary edema. There's a lot of things that you can get, but cerebral is probably the first one because it's the most sensitive to these changes. So your brain, of course, extremely sensitive to that, and that's why these patients often present with seizures. And I want you to remember that, because the opposite is true as well when we're trying to correct it. And of course, the opposite stands true for hypernatremia, which is when now the fluid moves from the extravascular space into the intravascular space. So that was what happened. So understanding hyponatremia. So it's basically a sodium level less than 135, sorry, not 136, 135 millimoles per liter. And I would say, amongst those who present like this with headache, nausea, seizures, confusion, and collapse, it's not a great many of them who do actually, end up being hyponatremic. But there's a good chance that if you work in a hospital, be it in a medical unit, ICU, or emergency department, you are going to come across significant hyponatremia at least 2 to 3 times a year. And the thing is, it is something that you need to be able to pick up, and it is something that you need to be able to treat. And it's the type of thing that even if you're working, for example, in a rural area, if you're working in an area without much in terms of support and things like that, it's something that you have to be able to correct as well. So that's what we're going to also discuss in a little while. So what could be the cause in an athlete? Now, in this case, they were thinking about excessive water intake or dilutional hyponatremia, or you get a syndrome of inappropriate ADH secretion, which is also a common thing that can arise from tumors, intracerebral tumors and things like that. However, in an athlete, you would think of excessive water intake. And I think in this particular case, that was the reason for the patient having such a severe hyponatremia. So those are some of the things that you think about. Now, why is it important that your sodium remains balanced? Well, the function of your sodium, it's essential for nerve function, fluid balance, muscle contraction, as we all know. And the main danger of low sodium is swelling of the brain cells or cerebral edema, as I had mentioned. Now, of course, like I say, every single cell in the body starts to swell up, but it's the brain that suffers the most from all of that. So, sometimes your patients may come in just confused. They may have ataxia, aphasia, things like that. But seizures are the most common presentation and eventually leading into coma and death as well. So, acute hyponatremia is not common. In other words, it doesn't normally happen over a case of an hour or two. It generally takes place over at least 8 to 12 hours that your patient starts experiencing this. And in some cases, your patient can take quite a long time before they become hyponatremic. So if you're working in an outpatient area and you notice a patient slowly, they may be having normal sodiums, but every time you're checking them up, they always seem to be going a little bit lower and lower. It is something to consider because they may have one of these underlying causes, which we'll talk about in a little while. So in this particular case, the pathophysiology of the hyponatremia, was excessive hydration, a dilution of the body's sodium levels, and that was why the patient had the seizures. Now, you may ask yourself, okay, then how did this person drink that much, And surely if he was an athlete, he should have sweated it all out. So that is true, and really that is what should have happened. And in going through the case while I was looking at it with the input of all of these guys, some extremely highly qualified doctors that were posting on that thread, a lot of them were worried about his underlying renal function, and they were also suspecting that even though he may have had a lot of fluids and been in quite a fit person, there could well still be another underlying cause because you wouldn't expect a young person to drink so much that they couldn't sweat it out. So, I mean, he would have had to have drunk between 7 to 8 liters of fluid in order to reach this stage. So even though initially this was the suspected cause, they did say that, in this particular case, the patient would need to be investigated and they would need to look at possible causes of why the patient still went under it. I must actually go back to the thread. I'm not sure if anybody's posted on it again, or if the original poster actually gave any more results, but I'll try and go back. It is about a month or two old, but I'll try and check that up, hopefully. So, sorry, I just want to hide this here. So this is probably one of the more important aspects of the talk today. So we're going to talk about how do you decide how you're going to manage or look for a cause of the hyponatremia. So if I was you, I would at some point stop, take a screenshot of this. It's a nice little a thing to have readily available on your phone or your device, whatever it may be, because essentially hyponatremia causes a lot of problems for students and young doctors because it looks very complicated, but it is actually very simple. The first thing that we need to know is osmolality. Now, if you're working in the emergency department, osmolality is not something that comes up very often, but it is something that you should know about. And I'll show you guys the osmolality calculator that I've got available so that if you do run into it. So the most common times we use it during electrolyte abnormalities, such as hyponatremia, and during things such as hyperglycemic states and things like that, which is where we need to know more or less what our osmolality is. So first, the two easy ones, which is isotonic and hypertonic hyponatremia. So isotonic merely means that the osmolality, or in other words, the osmotic pressure within the vessels is normal. So you don't have what you would call it a pull, for the fluid to go in and out of the vessel, as I had expressed earlier. And then, of course, you have hypertonic hyponatremia, which is where intravascularly there's a lot of osmotically active substances. So what that does is that it's actually forcing fluid into the intravascular space and causing a dilutional hyponatremia. So let's look at that. So isotonic hyponatremia, what it means is that you've got proteins and lipids that are causing fluid to actually come into the intravascular space, and that's causing the dilutional effects, or basically diluting your sodium levels that are there. And then hypertonic, it's when now the contributors to that are, of course, glucose, then external substances such as mannitol, sorbitol, glycerol, and maltose, and some radio contrast agents as well. So what these do is these create the hypoosmolar effects, and this also forces fluid in. But because it's not sodium that's the main problem, your sodium is sort of like a collateral damage, if I can put it that way. It's just caught in the crossfire, and it starts to decrease as well. So those are the two easy ones, isotonic and hypertonic. The one that always gets people is the hypotonic hyponatremia. So hypotonic, what it means is that there's too few osmotic substances within the intravascular space. And once you've got that, then it depends on the volume of the patient. So is the patient underhydrated, normally hydrated, or overly hydrated? That's the thing. So let's go through each of them. So your patient now has less osmotically active substances and is also has a low volume within there. So what that means is that in this case, there's no fluid that's being brought in from the extravascular space into the intravascular space. It means that the intravascular space is actually losing sodium. So that's the way that your patient becomes hyponatremic. So what happens is that as sodium is, in this case, as your sodium is being lost from the body, it is taking fluid with it, and therefore your patient becomes hypovolemic. So in these cases, there's two. There's, of course, extrarenal salt loss. So that means from dehydration, diarrhea, and vomiting. And in these cases, if you check the urine sodium, you'll find the urine sodium is actually very low, because where you're losing the sodium from is not the urine. All right. So it's from diarrhea, vomiting, dehydration. So that sodium is now coming out of the system, dragging fluid with it, but it's not necessarily via the kidneys. And then, of course, you have renal salt loss, where your urine sodium is greater than 20 milliequals per liter once you test it. And this means that as your sodium is passing through into your urine, it's pulling fluid with it, causing you to become hypovolemic, as well as lose osmotic any osmotically active substances as well. So these are common with diuretics, ACE inhibitors, nephropathies, mineralocorticoid deficiencies, cerebral sodium wasting syndrome. Now, of course, in the emergency department, you may not get to all of this, but if you are working in a medical ICU area, these are things that you need to know. Okay, I hope that made sense. Then, of course, we come again now, hypotonic. So there's less osmotically active substances, but your patient is not hypovolemic. Your patient is euvolemic. So this means that your patient has sufficient volume, doesn't have sufficient what you call it doesn't have sufficient osmotically active substances. So that means something is causing dilution. So what's causing dilution is, for example, your a syndrome of inappropriate antidiuretic hormone secretion. So antidiuretic hormone is what causes you to what you call it retain fluids into your system, as compared to a diuretic, which causes you to lose fluid. So your body is basically keeping all of that fluid inside, and again causing you to have a dilutional effect. Then there's others such as post-operative hyponatremia, hypothyroidism, psychogenic polydipsia, which I must be honest, I've never seen, beopotomania, idiosyncratic drug reactions to diuretics. Endurance exercises can also cause this, adrenocorticotropin deficiency. But I think from all of these, the most common are the top three over there that you would normally see. So it is something to think about. Then let's go to the last one. So the last one, basically, your patient is now fluid overloaded, but that fluid overload is what is causing the dilutional effect and what is making your patient hypotonic or has a low osmotic or low osmolality within the serum. And these are quite self-explanatory. Heart failure, liver disease, can happen in nephrotic syndrome and advanced kidney disease. So there are these things that are causing fluid to remain in the vascular space, but it's also causing this dilutional effect. So at the end of the day, the majority of the time, what's happening is that either you've got extrinsic or intrinsic causes of changes in your osmolality. And then based on that, you will have changes in your sodium levels from that as well, okay? So isotonic, protein and lipids, hypertonic, generally hyperglycemia and extrinsic agents. And then you come to the volume status again. So hypovolemic, you're either losing it from outside the kidney or from the kidney itself. You're secreting euvolemic, you're actually retaining more fluid, but maybe not enough to be considered hypervolemic, such as in these states. So I hope that makes sense. If it doesn't, please tell me. I'll try and explain it again. But I mean, I remember being in university and going through, about 4 or 5 or 6 lectures on this and still not really understanding it, because it can get very complicated. So the question is that, what do you do if you're sitting in an emergency area or you have an acute patient that's doing this? Of course, it's very good to look for all of these things. But for example, a urinalysis, urine sodium is not going to come back within an hour or two. So, the main thing is now, how do you get your patient out of danger? And the way that you get your patient out of danger is to give them sodium. However, the problem with that is that if you overload your patient with sodium or you give them sodium very quickly, you get something called osmotic demyelination syndrome. So we, especially those of us working in emergency departments or acute areas, we have a tendency to want to correct everything quickly. We want to get the patient back to as close to normal as quickly as possible. So we pump them full of bicarb, or we give them a whole lot of analgesics, or we, start bringing down their sugars with insulin as soon as they, they're hypoglycemic. We want to give them everything so that they don't die on us. That's how we look at it in the emergency department. But this is one case where you really have to step back and look at it. So to give you an example, patient comes in, patient has a fractured femur. We don't go and give the patient paracetamol, pethidine, morphine, sufenta, plus ketamine. We don't just bang them full of analgesics, because we know that we're going to cause problems. We're going to cause respiratory depression. We're going to kill this patient. So in the same way, when you're looking at hyponatremia, you've also got to get the sodium levels back to normal, but at a regulated rate. And if you don't, it really has quite significant repercussions, because this will lead to death, unfortunately, for the patient. So eventually, of course, if it's done too quickly. So I have seen this once, and it did happen when I was a younger doctor. I wish I could say it was me that did it, but it wasn't me. It was another doctor that I was working with as a younger doctor, and they had a similar problem like this in the medical department. And while we were on the rounds, we found out that this patient was experiencing osmotic demyelination syndrome. And it was a simple case of the patient had been given normal saline, actually not hypertonic saline, but had been given a large amount of it. And luckily, the patient survived, but it wasn't a nice thing to see. A patient going through this, and you can see the effects. There's further seizures. The patient goes into coma. It really was a mess. So, like I said, I've only seen it the once, and it wasn't pleasant to see. And I won't advise anybody to go through it at all. It's really one of those things where you look at yourself and you feel extremely small. And I really felt sorry for that guy. He was a really good doctor. I think from all of us who were in that particular group, he was probably the best or the second best. And he just made a mistake in prescribing the fluids and how much of fluid he was giving. And okay, in a way, it was his fault as well. He didn't ask for senior advice. He just kind of went ahead, maybe a bit sure of himself and headstrong because he was a good doctor, even though he was younger. But I think it humbled him a little bit as well. I'm thankful it wasn't me that was involved with the patient. I wouldn't have known what to do at that stage. So I often get questions from some of you guys who are quite young, interns, young doctors, and the questions you'll ask and say, I wish I was at yours level when I was yours age. I really couldn't have done half of the things that you guys do. But in any case, getting back to this, so the stepwise approach. So the ideal initial therapy is hypertonic saline, 3% saline. All right, if the patient is seizing. So if the patient is not seizing, it's not necessary to go as quickly with that. Now, hypertonic saline, to give you an example, most of us will use normal saline, which is 0.9%, all right? 0.9%, which is about 156 millimoles per liter. So if you had to extrapolate that and look at it at 3%, you're looking at closer to 480 millimoles per liter of sodium. So it's a large amount of sodium that you're going to put in. Now, they don't come in liter packets. They come in about 100 to 200 mils, depending on what your hospital uses, all right? And your rate of correction is no more than 8 to 10 millimoles per liter per 24 hours. So most of the time, what we'll do is we'll give about 100 mils of 3% normal hypertonic saline over about an hour or two. We recheck the sodiums and then give it on a very incremental basis because you can get a sudden rise in your sodium levels as well. So most of the time, there'll be an initial a large amount, like I say, 100 mils that's given, and then a slow infusion. Now, I'm not going to tell you exactly how much to give because a lot of ICUs have their own particular rates at which they prefer to run it and their own particular levels at which they prefer to switch off from hypertonic saline. So really, if you are stuck in this situation, the only thing to remember is that 100 mils, 3% hypertonic saline over about 1 to 2 hours. And then look at the protocols for your department or your ICU or your medical department, and then take it further from there. They don't often differ very much, but you may get slight changes. For example, one department will say switch to normal saline at 130, but another one will say switch to normal saline at 131. There's things like that, or there's some that will say, okay, you can give another 50 mils of 3% saline, and then you've got to recheck within an hour or two. So it really depends on each particular HOD and what they prefer and which school of thought they follow. And then it's extremely important to monitor the sodium levels, neurological status, and vital signs quite regularly as well. So how do we give it? It's only indicated in symptomatic hyponatremia. So if your patient is not having seizures, it's not really recommended to give hypertonic saline at all. You just continue with normal saline. And like I say, it's 100 mils of 3%. Sorry, I'm saying over 10. Okay, here that's correct. In the literature, it does say over 10 minutes. So I must apologize. That's a mistake of mine. I was thinking an hour or two is actually very long, but it's true. It is over 10 minutes. My apologies. That's my own mistake that I made. It is over 10 minutes. And then, of course, you've got to recheck and, you've got to then continue, as I had said. I'm so sorry that I made that mistake. I think I was thinking of something else, but and then you've got to monitor your sodium levels every 2 to 4 hours and observe for overcorrection. Now, as I say, once you've completed this, then of course you need to. So the question is, okay, I've given my 100 mils of 3% over 10 minutes. What do I do after that? Then you've got to redo your sodium levels, check, and then you've got to ask for assistance from your department's protocols to be able to see what's going on. So seizure control, you use any of your anti-epileptic drugs, for example, your benzodiazepines if needed, fluid resuscitation to prevent dilution further dilution of sodium. So you need to monitor your inputs and outputs quite well as well. And you treat the underlying cause if you know what's going on. So it depends on what cause you find. And for most patients, we won't find out in the emergency department, but you may find it a little bit later. Okay. So like I say, the main complication is demyelination syndrome. It's caused by overly rapid sodium correction, leading to irreversible brain damage. And the symptoms are dysarthria, quadriplegia, pseudobulbar palsy, and like I say, in some cases, death. Um, that patient that I had mentioned earlier when I was younger and had seen this, luckily it wasn't too bad. The guy actually made a good recovery after that. So it wasn't that bad, but it wasn't nice to see as well how he had suffered in that case. So what's the key takeaways? You correct sodium gradually to avoid complications. You treat the cause. You identify and manage underlying factors such as fluid overload, and the balance is key. Rapid correction for symptomatic patients, but control to avoid the demyelination syndrome. So just to recap, my apologies that I said over an hour or two. I'm not sure what I was remembering, but in any case, so 100 mils, 3% hypertonic saline given over 10 minutes. Depending on the type of packaging you have, so if you have it in a 200 ml, it does sometimes come in 500 ml as well. I would suggest the less experienced you are in treating hyponatremia, the slower you actually do it. Giving it over 10 minutes to 20 minutes, giving over 20 minutes to 30 minutes is not the end of the world because you can control seizures in the meantime. Do it at a rate that you are comfortable with while seeking senior assistance. It's not something that you as a junior doctor should be rushing to treat on your own. You shouldn't be trying to take the patient to that point that the patient is completely sorted out. You're just trying to get over that initial hyponatremia. Okay, so those are the key takeaways from that. So in conclusion, it's important that we work as a team. So the emergency management of hyponatremia, it's a coordinated approach between the ER, nurses, and the lab is very important in this case. Your lab needs to understand why you need the results quickly. Okay. And of course, post-treatment monitoring once you've figured out what the patient is going through. So this is just a little joke to sort of finish off, but there is one more thing that I would like to show you guys, and that has to do with osmolality. So what I'm going to do is that let me try and just get a okay, let me just try and get this up quickly. So I'm just going to stop the share here. I'm just going to pause the recording for a second and then restart it once I'm on that page. Okay. So the other thing that I was talking about was working out osmolality. So in order to make things a bit easier for people, I did set up an osmolality calculator. So it's on the ED Assistant, the Netlify app, that is linked in the description of the channel. And it's under the calculators here at the bottom. So I just want to get that up. So here's an osmolality calculator that you can use. It is a generally easy formula to remember, but in case you can't remember it and to work it out, because you do have to multiply and things like that. So let's take, for example, a patient with a sodium of 122, glucose, let's say, of 12, is not too high, and let's put a urea of 7. For example, okay, which is relatively within normal, okay, and we'll get an osmolality. So here it shows very low osmolality of 247 because our sodium is so low. So after that, you can go and have a look as to where you fall. So this is, of course, a low osmolality. The normal range is 275 to 295, more or less. So it just gives you an example of what may be the cause, and then, of course, the opposite may also be, let's say somebody, okay, no, 145, let's say 156, extremely high. Let's take somebody who's got very high sugars. And let's put our urea is ridiculously high as well. Let's put 129. Regular. Okay, very high. No, that's a bit, okay, let's make it a bit ridiculous. Let's make it 30. All right. Let's measure from there. So here you can see you've got, of course, an extremely high osmolality. So then it takes you through, what could be the causes of that. Okay. But in essence, it's impossible on a single page just to put all of that. So it's just to have an osmolality calculator. But in any case, I hope everybody enjoyed it, and I hope you learned something from that as well. If there's any questions, more than welcome to ask. And I say my apologies for the time of giving the hypertonic saline. I don't know how I messed that up. And yeah, hopefully we'll have another session soon. But if everybody's happy and if there's no questions, then we'll stop everything here. And I just want to thank all of you who joined me on the on the meeting live. I really do appreciate it. Okay, all right. So thank you very much and goodbye.